Good evening, everyone. We've got folks coming in from all over the country, and we've got some wonderful special guests tonight, and Dr. Dave Vigerust and Dr. Nathan Bryan. We're so excited to visit with them and ask them questions and pick their brains and learn uh, more from these two guys that are just world-class experts in what they do. And so Dave and Nathan, thank you so much for being with us. We really, really do appreciate it. And we'll wait a minute or so until everyone's here. Nathan, tell us where you're from.
I am born and raised in Texas, great state of Texas. So, yeah, spent the majority of my life here. Went to school in Louisiana at LSU School of Medicine, trained up in Boston, and then came back to Texas as quick as I could.
And you live outside of Austin. Is that the best description of where you live?
I'm about an hour northeast of Austin, out in the middle of nowhere on 800 acres.
And you have cattle.
I got a couple hundred head of cattle, got horses. We raise our own beef, grow our own food, and we're pretty self-sufficient at this point.
That's amazing. Yeah. And Dave, where's your home?
Right now, for the last 25 years, I've been in Nashville, but I grew up in Texas as well. Did the early part of my training in Texas and then came to Vanderbilt to Nashville in 99 to do my doctoral work here at Vanderbilt. And then stayed in Tennessee. I went to St. Jude and did a fellowship in infectious disease and then came back to Vanderbilt for a second fellowship and then stayed on faculty there. I still have an adjunct appointment, but for the most part, the last 10 years, I've been out of the full-time academics and into this entrepreneurial side of things in prevention medicine and diagnostics.
And I understand that you're a biker or cyclist.
I like, yeah, I like the kind of the purity of a simple machine like that. You know, it really feels good to get on the bike and feels like your lips just kind of open up once you start pedaling. So last couple of days we've had really nice weather, so I've had the opportunity to. First day I wasn't sure how my knees were going to take it, so I went 5 miles. Yesterday it was 7.5, and today was 12. So
good.
Trying to work up to a little bit of a spin every day.
Yeah, that's terrific.
Permitting, of course.
Yeah. And Nathan, you have a background in rodeoing.
I do. Yeah, my bike is the quarter horse. So I still rope and compete on weekends. I'll go to jackpot ropings, and yes, that's kind of my therapy.
Yeah. Wow. That's rough therapy for most of us. Well, why don't we go ahead and get started? Nathan, what we'd like to do, everyone, is spend about 30 minutes visiting with Nathan and then 30 minutes visiting with Dave about their areas of expertise. And I know we've had Nathan visit with us before with our study club, and his special area of interest is nitric oxide and that critical role of that miracle molecule, that gas in the body that has such a tremendous effect on our health. And Nathan has been involved in groundbreaking research for his whole career, working with 3 Nobel Prize winners that won the Nobel Prize. I think it was 98, wasn't it, Nathan?
98, that's right.
The discovery of the role of nitric oxide as a regulator of cardiovascular health and related to blood pressure, et cetera. So your work, Nathan, is opening up a new understanding of the role of nitric oxide in the body. Could you discuss a little bit with us tonight about the impact of nitric oxide related to oral health, and specifically, its relationship to periodontal disease, perhaps blood flow, overall health, whatever you think would be important for us to learn.
Yeah, well, thanks, Whit and Gina and Laura and everybody. It's great to be with you. Such a great group of people and really doing groundbreaking work yourself. So I'm excited about the future and our interactions and collaborations. But yeah, nitric oxide, it's still a relatively new discovery in the medical and scientific literature, just maybe 40 years old, discovered in the late 70s, early 80s. The interesting thing about this molecule is it's a gas, and once it's produced inside the body, it's gone in less than a second. And the guys that won the Nobel Prize were awarded the Nobel Prize because they were the ones who discovered that this molecule, this gas, is actually produced in the body, in the cardiovascular system. So the basis of the discovery was nitric oxide is a signaling molecule in the cardiovascular system. So now fast forward 25, 26 years, we now understand that that nitric oxide is actually produced in the oral cavity. It's not just produced by an enzyme found in the lining of the blood vessels and in the endothelial cells, because as we all know, there's enormous redundancy in the human body. And when it was discovered that nitric oxide is one of these critical signaling molecules, then it didn't make sense that there would be only one production pathway for the body to make nitric oxide. And at that, the enzymatic production of nitric oxide is a 5-electron oxidation. It's energetically and kinetically very unfavorable. So we were in search for this redundant compensatory pathway, and we stumbled upon this. And some of the early literature was published in the early 90s. And then we started in collaboration with the dental school of trying to understand if we could culture some of oral bacteria that were responsible for producing nitric oxide that was then be important in the regulation of systemic blood pressure. We published a number of papers on this, but to make a long story short, what we found was there's a diverse microbiome and specifically what we call nitrate-reducing bacteria. They're facultative anaerobes. They live in the crypts of the tongue, the ones that we've characterized and tried to culture. But they're responsible for taking inorganic nitrate that's found in some foods and dietary patterns, particularly green leafy vegetables, and converting that nitrate through a 2-electron reduction to nitrite. And then when we swallow our own saliva, nitric oxide is being produced in the lumen of the stomach. And so this, we call it an enterosalivary circuit because nitrate, once it's ingested in food, it's taken up in the duodenum or the proximal gut and concentrated in our salivary glands. Then when we salivate, the bacteria, if they're present, reduce nitrate to nitrite. We swallow our own saliva. If we have sufficient stomach acid, then this cycle produces nitric oxide. But problems occur when you disrupt the microbiome. And so in people with periodontal disease, gingivitis, oral dysbiosis, there's dysbiosis, and what that means is that you have the bad guys outcompete the good guys, and then the good guys can no longer do their job. And I think historically in dental medicine, you've taken this shotgun approach of, look, hey, we know that bacteria are responsible for gingivitis, periodontal disease. There's the oral systemic link. So let's kill the bacteria, right? But now we know, since the microbiome project, that you do this to your own demise. We have to maintain a healthy microbiome in the gut, in the oral cavity to maintain good systemic health. So what we're finding is that in patients who use mouthwash, chlorhexidine specifically, or other antiseptics like fluoride, fluorinated toothpaste, that this disrupts the oral microbiome, shuts down nitric oxide production. We see an increase in blood pressure. And we think, and we've argued, that this is the mechanism of the oral systemic link, meaning that people with poor oral hygiene have higher incidence of heart attack and stroke and onset of cardiovascular disease. And it's due to the disruption of the microbiome that leads to a decrease in nitric oxide production. And mechanistically, we know that the loss of nitric oxide is one of the earliest events in the onset and progression of cardiovascular disease. So now the challenge for us today is try to figure out, okay, how does the dental medicine community work with physicians, other healthcare practitioners, and all speak the same language? How do we mitigate the bacteria that are causing gingivitis, periodontal disease, halitosis, without killing throwing the baby out in the bathwater, right? And so I think that's the kind of the strategic alliance, is how do we selectively kill the bad guys while maintaining the good guys?
Excellent.
Yeah, go ahead.
Go ahead,
Go ahead.
Whit.
No,
Okay.
go ahead.
Thank you so much. We appreciate that perspective and your overview. A lot of people listening are new to the concept, and so that's a really great overview of your work and of nitric oxide. But also, one of the things that people have asked me about, and we want to hear more about, is your recent participation in the Reverse documentary. What did you learn there, and how was your experience, and what can we expect to see, particularly as it might be relevant to primarily dental colleagues on the call. However, we do have some MDs, DOs, and nurse practitioners as well.
Sure. Now, I've been very fortunate to be included in a lot of these new documentaries and docuseries, and and really trying to get our message out there. And so there's this emerging concept called longevity, of how do we live longer and better and free of disease. So this reversed docu-series was, I think they invited 8 experts around the world, and we flew into Costa Rica, which is one of the blue zones, where people live over 100, and it's not uncommon. And so the quest is, how can you mechanistically can we explain these centurions or these certain regions that they call blue zones, and what's contributing to their longevity and living life free of disease? And the interesting thing is there's now objective measures or tests of biological age. So there's really nothing we can do about our chronological age. I mean, every year we have birthdays and we get older chronologically, but it doesn't necessarily mean that biologically we have to age at the same rate. And I think, and I'm probably the perfect example. I turned 50 in November, but I've got a biological age of a 32-year-old. Despite being a meat-eating, Scotch-drinking Texan that travels all over the world and probably doesn't practice the most healthy habits most of the time or sometimes. So I think we're starting to understand what's leading to longevity. And so my participation, so there were physicians there were diagnostic companies there I'm not sure there were any dental medicine professionals there, although there should have been, and I'll recommend that for the next series, because I think the most important people in healthcare are the dentist, because they can either give you systemic disease or get rid of systemic disease. But no, look, it was a great experience. I spent 4 days in Costa Rica filming this series, and then I spent another 3 days there just exploring the jungle and enjoying the hot springs and the natural environment. But what we're finding is that longevity, to me, it's defined by 3 things. There's 3 objective, clinically proven measures of longevity. And one is telomeres. These are the ends of the chromosomes, and the shorter the telomeres, the shorter the lifespan, the longer telomeres, the longer lifespan. And I believe it's in 1996, it was discovered that nitric oxide actually controls and regulates the enzyme telomerase, which prevents telomere shortening. So if your body can't make nitric oxide, you don't get activation or expression of telomerase, and you get shorter telomeres. So there's a clear correlation now with that. And so if you can improve nitric oxide production, you have longer telomeres. The other are stem cells. The older we get, we're constantly wearing ourselves out, and we just got to repair and replace dysfunctional cells. And that's the role of our own stem cells. 20 years ago, it was thought that the older we get, the less stem cells we have. And I think that's true in bone marrow-derived stem cells. But fortunately, for most of us, the older we get, the more fat we have deposited, and there's a number of stem cells in our fat cells. So aging is not just a matter of loss of stem cells. It's the loss of the ability to mobilize stem cells to go and differentiate, to repair and replace dysfunctional cells, or these senescent cells. And so nitric oxide is the molecule that tells our own stem cells to mobilize and differentiate. So again, going back to this theme, if your body loses the ability to make nitric oxide, it loses the signal that tells our own stem cells to go and repair and replace. And then the third is mitochondria. The mitochondrial dysfunction is associated with every major chronic disease out there. And it's not only dysfunctional mitochondria, it's lower numbers of mitochondria per cell in sick people. And it's nitric oxide that controls ATP production in the mitochondria, prevents electron leakage across the electron transport chain, eliminates the oxidative stress, and nitric oxide is what activates PGC1 alpha to lead to mitochondrial biogenesis. So again, if your body loses the ability to produce nitric oxide, your mitochondria become dysfunctional, and you lose the ability to generate more mitochondria. And all these things like intermittent fasting, caloric restriction, physical exercise, sirtuins, NAD, all of these modalities are dependent upon the cell's ability to produce nitric oxide. So if the nitric oxide synthase enzyme is uncoupled and dysfunctional, intermittent fasting is not going to lead to more mitochondria, caloric restriction, physical exercise. So we have to focus on mechanism of fixing the cell's ability to produce nitric oxide, and then all these pathways are intact. So those are the 3 main things that I focused on the docu-series. And then there's a company called GlycanAge that can measure your biological age. There's DNA methylation test. We can also do carotid intima media thickness and look at stenosis of the carotids and the degree of smooth muscle proliferation. And there's algorithms out there that can assign you a biological age. You can look at reactive hyperemia in venous occlusion plethysmography. So there's different modalities and different metrics on this. And so what we're trying to do is, bring this to the fore and tell people, inform people that, look, we don't have all the answers, but we've solved a lot of the riddle in terms of what it takes to live free of disease. And a lot of it, the science is very complicated, but the solution is really pretty simple, right? It's a good diet, balanced diet in moderation. It's really elimination of all toxins, antiseptics, support the oral microbiome, the gut microbiome, and then we have to stay active. And we have to get nutrients from the foods we eat. Unfortunately, in the US, a lot of the foods we eat are depleted of many nutrients.
Mhm.
So that's kind of the overall message. Give your body what it needs and remove from the body what it doesn't need, and the body heals itself.
Yeah, I spent 2 years prior to overlapping with the current company that I'm with, working with a company. It was a spin out from the Thousand Immunomes project at Stanford. And we had a biological clock of sorts that basically determined what your immunological age was and looked at some of those same kind of populations. We had a number of participants in our clinical trial that were in their 20s, but they had an immune age of someone in their 70s.
Oh,
And we
yeah.
had a couple of people who were 105, 106 years old, from blue zone areas, kind of thing. And we tested them, and their immunological age was someone in their 20s. They had a very robust immune system. They were able to properly address, all of the threats and concerns that you get hit with environment and toxin and infection and everything else. And we spent a fair bit of time looking at microbiome and looking at their blood work and looking at their the full immune profile to see if we could identify molecules of interest that would help us to determine that their immune system at least was moving in a direction that was characteristic of someone more aged. And the intent there was to try to help to mitigate and identify patients who had a higher risk for age-related diseases, cardiovascular disease, stroke, the whole laundry list of things that happen to us get older. Yeah. So I know
Well,
there's a number of those clocks out there, right?
Yeah.
Horvath has a clock. There's an epigenetic clock. There's a number of them out there that are all trying to get to this question of how do we properly identify somebody that needs some intervention and try to move them in the right direction.
The striking thing for me, and it was my first trip to Costa Rica. I mean, it's a pristine environment. They're laborers. They move around and they're exposed. I mean, the foods they eat are come directly from the market. It's freshly grown from local farmers. You don't see the chemtrails in the sky. There's probably no chemicals, but they're getting in these volcano regions in the rainforest, the soils are replete in all the basic minerals and nutrients and elements. So their food is nutritious. They're not exposed to chemicals. The water supply, these hot springs have all the basic minerals in it. It's flowing water. It's a source of electrons. And it's just, soaking that in and being in that environment. I mean, I can feel the energy. I mean, I left there feeling really energized.
Nathan, relative to emerging trends in nitric oxide research, what are the things that you find the most exciting, and perhaps how might these end up influencing our work in dentistry?
Well, it's moving at an enormous rate. When I started in the field in the late 90s, I think there were probably 20,000 scientific papers on nitric oxide. Today, last week, I did a search, and I think there's over 190,000 published articles on PubMed. Most of it's noise. It's a misinterpretation of basic experimental data. But what we're finding is that nitric oxide is foundational. It's not an end-all, be-all, cure-all, but your body cannot and will not heal without proper nitric oxide production. And now that we know kind of the basic mechanisms of how the human body produces nitric oxide, Once it's produced, where does it go? What does it become? And and now we can capture that therapeutically. I think what we're finding in through some of our drug trials is that, if you can restore and recapitulate nitric oxide production and signaling, you can really address a lot of major poorly managed diseases that we've dealt with for the past 50, 60 years. The fact that cardiovascular disease remains the #1 killer of men and women worldwide today is, to me, completely unacceptable, because the science tells us unequivocally what causes cardiovascular disease. We know how to diagnose it, and we know how to treat it. So the problem is just the dissemination of the information and the implementation of the science into clinical practice. And we know that it takes on average 17 years for new discoveries to become, point of care and introduced into clinical practice. But, we're 25 years, 26 years now post Nobel Prize, almost 50 years post the discovery of nitric oxide. So there are no excuses. And I think the limitations is what we're dealing with, is that no one's been able to get a nitric oxide drug to market so physicians can then use that therapeutically. And I think the other limitation is there's not any labs for nitric oxide deficiency, right? Because it's a gas, it's produced, it's gone in less than a second. So we can't, like cholesterol or vitamin D, draw labs and go, oh, you're low, or you're high, let's give you a cholesterol blocker, or let's supplement what's missing. But I think all that's about to change. We've got drugs in phase 3 clinical trials. We're the first and only people to ever make a solid dose form of nitric oxide gas that completely recapitulates nitric oxide production and signaling, and we're seeing enormous improvement in ischemic heart disease. There's 33 million Americans that live with ischemic heart disease. The cornerstone therapies are organic nitrates, which long-term outcome data show that patients actually get worse, and patients develop tolerance to these drugs. So they have to wean off, have an off period. And it's during that off period that most people suffer heart attacks, because they get the ischemic comes around and the plaque becomes unstable, and you get plaque rupture and heart attack. So what we're finding is, through our nitric oxide drug, the lozenge, that we can alleviate the ischemic pain known as angina. We can eliminate exertional angina and prolong, if not completely eliminate, exertional angina, because we dilate the coronary arteries and we stabilize plaque, and we reduce inflammation, oxidative stress, and immune dysfunction. So I think we're seeing great progress there. We've got a drug going in for Alzheimer's. We published in 2009 that nitric oxide is part of the insulin signaling pathway. So in Alzheimer's patients, they have reduced blood flow as measured by SPECT or functional MRI to the brain. They have insulin resistance. It's called diabetes type 3. And nitric oxide restores cerebral blood flow. It improves glucose uptake and insulin signaling. So that single molecule overcomes all the metabolic phenotypes of Alzheimer's disease and vascular dementia. So we're seeing that our drug is improving cerebral blood flow. We can improve cognition. And I think, as with any disease, there's probably a point where no therapy is going to be effective. But I think if we can catch these patients early on when they develop mild cognitive disorders or vascular dementia or even early Alzheimer's, then our early clinical data show us that we can certainly slow the onset. Best case scenario, we can actually reverse disease. And then I'm most excited about our topical nitric oxide, because we're healing, non-healing wounds, diabetic ulcers, with nitric oxide, topical nitric oxide we develop. And most of you know there's been no innovations in wound care for the past 50 years. We treat wounds today the same way we did 50 years ago: negative pressure and collagenase and a little bit of collagen and debriding the wound and hoping it heals. But our topical nitric oxide kills the infection that's present in most non-healing wounds. It causes hyperemia, recruits capillaries, gets blood flow to the wound, tissue granulation, and there's not been a single wound we haven't been able to heal with nitric oxide. So we're moving that through phase 3 clinical trials. So I think the treatment aspects of nitric oxide is very exciting, but I think for me, what we have to do is be proactive, because treatment is reactive. And I think once we understand and all come together, the dental community, the basic scientists, and the medical community, and we certainly understand the mechanism of disease today for most diseases, and then be proactive, and then start to employ strategies that prevent the loss of nitric oxide production. And look, again, there are other things you got to address, but I think foundationally, if we can affect nitric oxide and then deal with other issues, if you're exposed to toxins or have hormone issues, or you have, cavities or gingivitis or periodontal disease, then we can address that. But if you restore nitric oxide and you restore the oral microbiome, these good bacteria, these commensal non-pathogenic bacteria, actually keep the bad guys at bay. It's when you have dysbiosis that the opportunistic bacteria overcome, and that's what leads, at least from my perspective, to the bad guys that are causing, gingivitis, periodontal disease, halitosis. So if you restore the communities, restore nitric oxide, you improve blood flow, you reduce inflammation, oxidative stress, and immune dysfunction. And you see that in every chronic disease, not just oral disease, but systemic disease.
Mhm.
I think, Dr. Bryan, so many great points that you brought out there. One thing I would like to recap is the topical application, because any of you who haven't heard Dr. Bryan speak and show the case studies and the pictures and the improvements, it's incredible. But the other thing I wanted you to elaborate on is so many people have asked about testing the saliva with the test strips, and we've discouraged that just because in my own clinical practice, I've seen so many discrepancies. And so if we're not using those, which I don't recommend, you can tell us your thoughts. I tell patients these are the things we're looking for. One is, of course, lowering of blood pressure. The other is any improvement in athletic performance, or just even if you're a everyday exercise person, your endurance, your stamina, and of course, sexual performance as well. Would you add to that list and tell us how you explain it to patients, for example, and what they can expect to see to know that it's improving your N101 or N240U?
Yeah, like the test strips, I developed those about 15 years ago because the question was at the time, how do I know if I'm nitric oxide deficient? And again, there's no labs. We can't draw peripheral blood. We're relying on symptoms. And so the test strips is measuring salivary nitrite. And so through this enterosalivary circuit, if you get the right oral bacteria and you're producing nitrite from nitrate, we can use that diazonium salt. It's called the grease reaction. It's an old chemical reaction. We can capture that on a test strip. And as you, Gina, what we've learned from you and many others is that there's a lot of false positives because you have a 50-year-old obese hypertensive diabetic man with ED. You test his saliva and he lights it up like a Christmas tree. Well, obviously that guy is not making sufficient nitric oxide. He's got an active oral infection. So what we're finding is that accumulation of nitrite in the saliva is a local immune response, either from an active oral infection or just gingivitis, the inflammation in the gums. So because of the false positives, we've gotten away from that test strip. So now we're finding that we really have to rely on symptoms. And there's a hierarchy of symptoms we start to see when people start to become nitric oxide deficient. The first one typically is some degree of sexual dysfunction. And that's in both men and women, because if your blood vessels can't make nitric oxide, you don't get dilation, you don't get engorgement, and you develop erectile dysfunction. And it's both penile and clitoral erections. And so you see that, and 50% of the men over the age of 40 self-report ED. I think the numbers are much higher because most men aren't going to self-report erectile dysfunction. So that's the canary in the coal mine. And then when you start to see an elevation in blood pressure, then you've gone to more of your, your resistance arteries and endothelial dysfunction. And it's systemic. And then so you see an increase in blood pressure. And then you start to see an exercise intolerance. If you get short of breath or winded going up a flight of steps, if you can't do simple aerobic exercise for 20 or 30 minutes, without being able to carry on a conversation, then it's nitric oxide deficient. When you start to lose your memory, it's loss of cerebral blood flow, and that sets the stage for dementia and Alzheimer's. So those are kind of the hierarchy of clinical symptoms we see. And the other is metabolic disease, because as I mentioned earlier, nitric oxide is part of insulin signaling. When insulin binds to the insulin receptors on cells, it activates PI3-AKT kinase, which leads to nitric oxide activation, and then it's nitric oxide that post-translationally modifies GLUT4 to go to the membrane, bind glucose, and bring it into the cell. So if the cell can't make nitric oxide, you get insulin resistance, and you can't bring glucose into the cell, and you get hyperglycemia, hyperinsulinemia, and everything goes downhill from there. So those are kind of what we rely on, and we've gotten away from the test strips for those reasons. And I tell people there's only two people who need nitric oxide, It's the sick people who want to get healthy, and it's the healthy people who don't want to get sick. So if you're one of those two people, then you probably need nitric oxide.
Hmm. Well, currently in our dental practice, we're trying to do as much as we can to boost nitric oxide through encouraging our patients to be involved with a excellent nutritionist that we've worked with, and work with that, plant-based diet as much as possible with foods that are rich in nitrogen. And then we do a lot of mouth taping, trying to encourage nasal breathing, and also supplementation with lozenges. So I think that's pretty much our boosters right now. But the other is still in a period of flux, and that is what to do with mouthwash and mouth rinses. And so we get a lot of questions, and I don't know that I would ask you to answer this tonight, but of certain rinses that are known to be more natural and plant-based, which let me just ask you, would you say that a natural plant-based mouth rinse would be more desirable than Listerine, for example?
I think anything is going to be more desirable than Listerine.
Okay.
Nothing, yeah. No, I think, look, we've tested a lot of these, and some of them are pretty innocuous in terms of destroying the microbiome.
Yeah.
But most of them, we just don't have the data. When I was still in academia, and I kind of followed the same career path as Dave, been in academia for 20 years, and then retired and stepping into this entrepreneur role. But I still have my feet into the research lab where we do testing. But years ago, we would file NIH grants to try to answer these really important questions on what is destroying the oral microbiome. And every grant that I submitted to every study section was denied. I mean, they wouldn't even review it.
Mhm.
And so I don't know if it was just maybe I got several grants funded, so maybe it's not my grantsmanship, but maybe it was just that what we were doing maybe wasn't right for NIH funding at the time. But the point is, there's a lot that we don't know in terms of mouth rinses that may be affecting the oral microbiome positively or negatively. But here's what we do know. Things like chlorhexidine, alcohol-based mouthwash, fluoride-based mouthwash, all these are antiseptics. So when the Listerine commercials tell you that it kills 99.99% of the bacteria, believe them. And that's not a good thing, by the way. But we're working on this. This has been a 2-year project for me to try to figure out, because 2 out of 3 Americans use mouthwash, and 2 out of 3 Americans have an unsafe elevation in blood pressure, and I don't think it's coincidental. So I think we've been programmed to do that. So I don't, and some people, need a healthy mouth rinse. So what I've been trying to do, and I hope to have this launched probably Q2 or Q3 of this year, is creating a nitric oxide friendly mouth rinse. So we certainly understand these microbes in these communities now. We know what they need to flourish. We know what we need to repopulate them. And then also trying to understand what are some natural products we can put in there that'll leave you with a fresh breath, that not only that doesn't destroy the bacteria, but actually improves the diversity of the microbiome. So now you get the best of both worlds. You can get a fresh breath, and we're helping the oral microbiome. And then through collaboration with you guys, figure out, okay, if we restore the health of the microbiome, can we mitigate the bad guys that are associated with, gingivitis and periodontal disease, and get inside those cracks and crevices and show a clinical benefit from that without the use of antibiotics.
Right. Well, that would be very exciting, and we're going to be first in line, both to use those products and hopefully maybe even to invest in them, because they sound like they would be a tremendous investment for the future. Thank you, Nathan. I know you've got to go to a dinner in just a little bit, but thanks so much for being with us. You're so generous with your time, and we know how valuable it is.
Thank you,
Yeah. Well, Dave, we want to ask you a few questions, of course. And why don't we just start? I want to ask you to go ahead and share with many people on this call that have not met you personally yet, a little bit about your background and how we've come to work together with Gina and Laura.
Okay. So as I mentioned earlier, I spent the earlier part of my career in academics. I, for the most part, was working in areas of the immune response to infection. So I was very interested in viral bacterial synergism, how our immune system responds to those kinds of infections. Early on, it was in the area of HIV biology. So I was trying to understand the early interactions between HIV infection and our immune system. How does it move from an entropic? So HIV is one of those viruses that once it comes into the mucosa, it has a tendency to target our naturally born immune system. And it does that for a period of time before it transitions over into our adaptive side. But there are a lot of avenues where that virus is cooperating in ways with other parts of the microbiome. So I was interested in that for a period of time. And then when I went to St. Jude, I switched into a respiratory biology model where I was looking at, again, bacterial synergism and how the immune system works. And I did that for a number of years at Vanderbilt, and then was recruited out of Vanderbilt into a prevention laboratory diagnostic company. So we were very interested in trying to develop new methods and new tools for identifying patients who had, early onset of diabetes or cardiovascular disease. We were in stroke prevention. So we were really trying to develop assays that would help us and clinicians get some early insight on which patients had the risk, which patients do we need to focus some attention on. And in doing that, I started working with Brad Bale and Amy Doneen, and got involved in their preceptorship and how they go about training physicians and dentists on, what to look for and how to try to keep their patients from having and suffering from cardiovascular and cerebrovascular issues. And as I was doing that, I moved between a couple of different laboratories. We, for the most part, was focusing around prevention. I spent a number of years in infectious disease. Again, I went back to another lab that was doing principally infectious disease, and we had tried to develop a periodontal panel at that first company that I was recruited out into. And it was mostly as a competing product against, the big one in the market right now, oral DNA. We pursued that for a little while, and then I got recruited out to another company, but I continued to have this interest in the oral microbiome and how it contributed to systemic disease. So the last 10 years, I've been trying to better educate myself on the field and trying to offer tools to clinicians on how they can identify patients at risk. So at one point, Brad and Amy were coming to me with, hey, we really need to have a test that does this, that looks for, at one time, they were asking me to help them develop an assay for haptoglobin, a protein that's involved in leaky gut syndrome and oxidative stress. It does a number of things that are really nasty when it comes to cardiovascular and cerebral vascular health. So we developed some assays for them, and Gina's familiar with some of that work. And I think there have been a number of providers that have adopted that as one tool in trying to identify patients that have a risk for leaky gut syndrome, that have a risk for oxidative stress and cardiovascular issues as a result of that not error, but alternate protein type.
So Dave, I would love for you to elaborate just a little bit, because most of us, well, I'm not sure who else is on the call, but certainly those of us that have been in the IDM community are very familiar with your landmark study that you co-authored, identifying for us the pathophysiology of exactly how these pathogens are so disruptive in the endothelial lining of the blood vessels, of the arteries specifically. But in addition to that, well, and for those of you who don't know, Dave is a thought leader for sure in this area, and is numerous publications, not just that one. It's just the one we talk about so much because we were all celebrating that somebody's finally helping us understand exactly what's happening there in the wall of the artery. But elaborate a little bit on significant conditions that we're seeing in the medical office and how these bacterial pathogens and the altered oral microbiome Like, what's the current research and what else do we know since that Langenbark paper came out? We all know that PG, AA, TD, TF, and somewhat FN, we have to treat those. Like, we can't ignore them anymore. I know your paper and others since have helped us to understand that 50% of heart attacks, at least, if I think it's higher than that, that's just my clinical opinion based on what I see in my practice, are related to these pathogens. We have
Mhm.
trouble getting rid of these pathogens if we don't treat airway conditions and all of that. But anyway, just bring us up to date on what are you studying now and what else do you know about the relationship? What do we need to know that maybe we don't, because we don't have our head in the research like you do?
Yeah, we've been spending a little bit of time investigating the role that some of these organisms have on other types of systemic disease like fatty liver disease. So, and I think that there's a connection with some of the stuff that I had done in the past along with this. So there is a growing understanding that, we swallow somewhere close to maybe a liter of saliva a day. It's a significant amount of saliva that we swallow. And if you have an active infection with Porphyromonas, for example, you're swallowing a significant amount of bacteria into the gut. If you are likewise suffering from any form of leaky gut syndrome, then you're allowing that organism, which has its own mechanisms for extravasating from the lumen of the gut and into the blood vessel, you're allowing an additional avenue of entry into the vasculature and into the systemic, into the blood system. So we know that there are a number of virulence islands on Porphyromonas in particular that are driving a lot of systemic disease in the inflammation within the liver. So once they get to the liver, they result in oxidative stress. They tend to oxidize lipids. They tend to inflame the architecture of the liver. And then you end up over time, just generating a tremendous amount of scar tissue in the liver. Ultimately, that can lead to cirrhosis, and in worst cases, it can lead to hepatocellular carcinoma. So the reason why I think that previous work that we were doing with haptoglobin is important here is that haptoglobin is a known protein that results in the relaxation of gap junctions in the gut. So if you're a haptoglobin 2.2 or haptoglobin 2.1 positive, you have a tendency to have somewhat relaxed gap junctions in the epithelium of the gut. If that happens, then you're giving an increased avenue for transit of Porphyromonas into the blood, and it can reach into the kidneys and the liver. So we're starting to do maybe a little bit more investigation and work on that, trying to work with some gastroenterologists here in Nashville to do a better, more controlled study on, for those patients that have significant fatty liver disease, do they also have a history of periodontal disease? And can we also show that they may have protein structures that are resulting in them having this leaky gut syndrome, which also transmits into the oral cavity, that also makes those gap junctions in the oral epithelium more relaxed and leaky to allow extravasation in the oral cavity into the bloodstream. So you're actually getting hit twice. You're getting hit out of the mouth and you're getting hit in the gut. And then obviously swallowing things like Fusobacterium and the Agritobacter. Fusobacterium has a known connection to colon cancer. It has a known connection to some other systemic diseases. So it's really valuable and important to have a really good assessment of the oral cavity and understand what's there. And it was really interesting that Dr. Bryan was mentioning that, some of these organisms are really vital to the production of nitric oxide. I don't think anybody is really looking at what's the status of those organisms in some of the testing that's being done, right? So the saliva testing we're doing now is for the most part directed against the pathologic organisms. Not a whole lot is being done on the good commensal organisms. So maybe that's an avenue for improvement in all of us when we're doing the saliva testing. Maybe we should be looking for these organisms as well to see if there's a healthy colony of those organisms. And, maybe you can come to a good balance in trying to eliminate the pathologic ones and support and maintain the healthy good ones that are contributing to nitric oxide production.
Excellent. I agree. Love that perspective because it is all about supporting the good, and we need to understand that better for sure.
Well,
And
our tendency sometimes is to just kind of go in and nuke everything, right?
yeah,
Um,
that's right.
Mouthwashes and rinses and antibiotics and everything else. You just want to get rid of it. And I think the understanding that you're also in the process eliminating a myriad of really good, healthy bacteria that need to be there, that are offering all kinds of support to us metabolically and otherwise, that we're
Mhm.
doing just as much damage by taking those kinds of, nuclear approaches.
Mhm. Exactly. It's such a good point because at IDM, we are teaching based on the science that we do have. We need so much more research, of course. But like when you're sitting there looking at an individual that's high risk for a heart attack or for stroke, or maybe has already had one, had stents, had bypass surgery, yeah, it's top priority to get rid of PG and AA and for sure, and some of the others. So we do sometimes recommend oral antibiotics, which we hate. We don't love using systemic antibiotics, but taking a thoughtful approach of healing the gut, putting oral probiotics as well as GI probiotics in, and a lot of other good things before you start the antibiotics. And then as soon as you're done with the antibiotics, to try to repair what damage, because you have to weigh the risk versus benefit of using, like you say, a nuclear bomb. Okay, it's going to get rid of them, but at the same time, we know we're doing some harm. So we need better strategies, and your research is going to really.
Unfortunately, we don't have any highly selective treatment approaches, right? That only target porphyromonas, that only target Tannerella, that only target treponema. Because you have, somewhat similar biology across a whole host of organisms, you're basically killing everything that has that particular mechanism,
Right. Yeah.
right?
Yeah. And closely tied to that as well, one of the questions we received ahead of time before tonight is very relevant here, because they were saying, is it really necessary for medical and dental offices and teams to work together? And is it really going to happen? And all of kind of the challenges with that. But I think this is a perfect example of how we just have to. We have to keep driving this movement forward, because it's not going to do me any good to give antibiotics in the medical office if they haven't been evaluated in the dental office and also treated appropriately there, and vice versa. It really does take both teams to save an individual's life
Yeah,
and to give them that life.
it's been a long road. I mean, the medical community has utilized dentistry in a very small, limited number of occasions, right? So if you were having a knee replacement, or you're having a joint, or some kind of orthopedic procedure, there used to be, I'm not sure if there still is or not, there used to be a protocol that you'd have to get a clearance from your dentist before you could have that procedure. Same thing with a stent placement and things like that. But really, those are the only occasions where you really had a dialogue between the dentist and the medical provider. And I think there's really a missed opportunity there. The dentist has a very important role. You're going to see those patients a lot more than the physician does. I mean, I see my doctor for a physical maybe once a year. Um, if I have time and I'm thinking about it, right? But you probably see your dentist multiple times through the years. So they have a very unique opportunity and position to help with the overall welfare systemically and otherwise of the patient. And there just hasn't been enough of this collaboration and dialogue between the two to really facilitate that. It's starting to get better, I think. But it really, it takes trailblazers like yourselves who are out there trying to teach, trying to say, this is the reason why you want to do it. And it's beneficial to both practices. It's beneficial to the medical practice by referring to the dentist to make sure that the patient has, everything taken care of in that regard, and there's not a risk that's coming from an infection or anything else, and vice versa. You have this opportunity now to make this collaboration and really do tremendous benefit to your patients.
Dave, one of the things we've been racking our brains on, that is Gina and Laura and myself, is how to bridge the gap, and also with the public in a way that is logical and easy to understand and compelling. And so as we're talking about leaky gums and leaky guts and leaky arteries and leaky brains, and now it sounds like leaky livers as well, we're really playing with this idea of what we're calling leaky syndrome, and something where behind the scenes of systemic inflammation, which is really just an effect and symptom, is something that's driving this. And it seems to be that there's a connection with these different problems of porosity, or whatever you want to call it, where things are getting into the wrong place and the wrong things in such a way that it becomes really damaging. We're very interested in dentistry with salivary testing, obviously. It's so easy for us, and it's so much more comfortable, than thinking about drawing blood in a dental office. And so we're very interested in what you're seeing in your laboratory and thinking about, as far as, for example, in Gina's practice, well, she'll do blood draws to look at inflammatory markers for vascular inflammation. Obviously, that's something we feel that we should be doing as well. Many of us aren't really ready to start routinely drawing blood or ordering labs, but do you see these things as something that will come relative to salivary testing in the future?
Yes, and in the very near future. I was mentioning a little bit earlier about that project that I was working on. It was the immune project. It was a spin out from Stanford. As part of that study, we were collecting saliva on every one of those patients that were part of our clinical trial. And I looked at those patients in terms of their infection, their oral infection. So I looked to see, do they have Porphyromonas? Do they have Agrobacter? Do they have any of those organisms? But I also looked at a panel of 7,500 proteins that are common proteins associated with disease. So we were able to identify nearly 7,500 out of the salivaome, if you want to call it that, the proteome in the saliva. So from that set of studies, I'm fairly confident that we can identify a fairly broad range of clinically relevant analytes out of saliva. I know we can measure, I've done it in the past, I know we can measure inflammatory proteins, both proteins, and we can also measure the genetic signatures. So I can look at genetic anomalies in IL-1, IL-6, TNF that would speak to somebody who is going to be more prone to hyperexpression of any of those pro-inflammatory molecules. There is also proteins that we can measure in terms of viral infections. So I think some of you know that our particular panel includes some viral targets as well. Those viral targets are known to induce the expression of both pro-inflammatory and anti-inflammatory, and they affect the body's ability to effectively target and eliminate some of these bacteria. So there's a lot of advancement that's coming in the space of saliva diagnostics. So, for example, you would typically go and get a blood draw if you were going to do your liver enzymes, if you were going to measure your ALT, AST, GGT, just to kind of give you a picture, an enzymatic picture of how your liver is functioning. I can measure those molecules with saliva without having to go and get a blood draw. Now, we can't measure everything under the sun using saliva, but we can measure a fairly good number of them and allow for a non-invasive remote testing environment. So you as a clinician could say, well, I want to follow you every couple of months or every month on how you're responding to the treatment. And we could follow those inflammatory molecules and you could see whether they're increasing or decreasing. And using saliva as a non-invasive collection mechanism is an ideal way of doing that.
Yeah.
So there's more and more of that coming. The other thing is, blood has always been the gold standard for diagnostics. And a lot of the manufacturers of the instrumentation that you use to measure these analytes have never considered saliva as a viable sample type. So there's some growing interest in some of the big companies out there now that produce the instrumentation to measure these analytes to use saliva as an alternate sample type, because we know that people feel more comfortable giving a saliva sample than they did going and getting a blood draw. It's just more convenient. There are people obviously who are needle phobic. Our own company, as part of our diagnostic acquisition last year of the laboratory, we also acquired a microarray production facility. And by doing that, we can design our own assays. So if a clinician were to come and say, I really need XYZ proteins, we could custom design an assay for those proteins to give you the clinical information that you need, and do it in a way that has a high degree of sensitivity, specificity, and precision. So the instrumentation is getting better. Technology is getting better at detecting these analytes in an alternate sample type like saliva. So I think the next year or so, we're going to see a growing interest in saliva as a sample type, and using it as a means for monitoring in a remote fashion your patients. So you can monitor their inflammatory profile, you can monitor their liver enzymes, you can monitor their responsiveness to treatment and to intervention.
So there is a certain amount of serum that's recirculating into the mouth. Is that what we're able to draw from, other than,
Yeah, well, the salivary glands do produce and transmit from the bloodstream. They transmit many of these proteins into the oral cavity.
Yeah.
So, like for example, we have the production of immunoglobulins that serve as a protective mechanism and opsonization of organisms that come in the mouth, right? So those are secreted through the salivary glands, and they come from the blood, but they transit through the salivary gland into the saliva. And then you also get some of that production through the fluids that are being pushed up, from the gums and out into the oral cavity.
Right. What about sugars? Is there any way to have any sort of measure through saliva of what's going on with blood sugar levels, insulin, anything like that?
There are surrogates for glucose. So there are surrogates that you can use for your glucose. You don't get a lot of glucose into the saliva. You do get other types of sugars that can serve as a surrogate. So there is a little bit of that that's being explored now also from our company, but also from others, to look to see whether saliva can be a good sample type for monitoring diabetes, insulin, sugars, and that sort of thing. There's a whole field of glycomics, of people who are interested in studying the variety of different sugars that are participating in biology and in disease.
Yeah. Because I think from our perspective, we could see testing on a regular basis saliva for both the pathogens and things related to sugars and inflammatory markers. I mean, these would be the things we would just be looking at all the time. So if you know of a lab that would like to start doing this a lot, we can be the clients. We would be happy to start ordering the tests, if there's a shortage because there's no demand, then we'll work on that.
Yeah, our own group has started to explore looking at sugars in the saliva as a surrogate means for monitoring diabetes and such.
Right.
Because we have some clients that are in the prevention, employee benefits and prevention space. So they're large corporations that are trying to get a good handle on heart disease and diabetes and metabolic disorders. And they're interested in being able to do this in a non-invasive fashion. So we're really looking to try to innovate in that space and provide some tools that can be deployed to the clinician that don't require a blood draw.
Right. Great. Well, one of the reasons that we invited Dave to join us tonight was not only so that you could get to know him a little bit, but also to promote the opportunity to meet him in person, because we're going to be together in Knoxville in May. And Dave, you won't have that far to travel, will you, living in Nashville?
About 3 hours. It's about 3 hours.
Maybe 3 hours. But we're so excited. I hope you all that are part of the IDM Scholar Society community and family here can see how we have been excited to connect with true pioneering experts. And we're so looking forward to doing something that is really a first ever event, and that is to combine medical, dental, nursing, and dental hygiene at one event. And so we're bringing Nathan and we're bringing Dave and others to participate there and spend time with you over the weekend as you join us. And we're so sorry that Dean Denise Cook could not be with us tonight. She was going to join us and we were going to talk with her, but she came down with COVID just a day or two ago and is really under the weather. And so she asked to be able to visit with us on another date. But I hope that you all have in your calendars our next big event, which is May 17th and 18th in Knoxville at the IDM Scholar Society LMU joint event together. And I think we shared with you last time we were together about this event, but what we're going to actually do is the first day, which would be Thursday, we're going to meet with the students and the faculty at the school and introduce them to this whole concept of integrative dental medicine. And so we'll have, hopefully we believe there will be all the medical, dental, hygiene, and nursing students at LMU University in one room together in an auditorium that holds about 300 to share with them the concepts of oral and systemic medicine and how they're vitally linked to each other and should be part of their future as they diagnose and treat their patients. And so that'll be the first time that's ever been done. And then on Friday and Saturday, we'll have our symposium that you're all invited to, and we're bringing in some incredible speakers, and we're so excited about that, from medicine, from dentistry, from nursing, from hygiene, PhDs, to share their research and to really stimulate this brand new field of combining dentistry and medicine. And so the dean at the dental school, Denise Cook, contacted Laura and then Gina and Ann Rice and then myself to come work with them and to integrate these concepts because they want to be the top school in the country. And they realize that what we're all talking about together, which nobody's done, is really where the future is. And so we're super excited about that, and just really can't wait to get there and make this all happen. Gina, tell us more about that if whatever you're thinking about.
Yeah, so I think that a couple of things I would love for everybody to know is that it won't be exactly like, well, obviously you've given us many reasons why it won't be like last year's symposium, as fantastic as it was. We got rave reviews on it, and a lot of the speakers are coming back. But we're going to do more case discussion and actually giving examples. For example, we'll have a cardiologist there, Dr. Joseph Puma from New York. He has seen some patients in conjunction with myself and with Victor Avis, a dentist. Most of you are familiar with Victor Avis and the Airway Revolution Foundation. We will be presenting a few cases. We'll present some cases with the oral surgeon and the dental community who've collaborated together both pre-op, peri-op, and post-op on the patient's case. And hopefully we'll have, one of those is very recent, and so we're hoping to have some follow-up data on the oral microbiome, the GI microbiome, and how the patient did, perhaps preferably or better than those who didn't have a dental and a medical team collaborating during the pre and post-op period. And that would just be a case study. We're hoping, Dave, to have a bigger paper and a large data set come out of those few examples that we have. But anyway, we're going to make it very practical, not only just in case studies, but in the ways that we engage in this conversation and the collaborative collaborative efforts, how do we actually communicate about the patient and inform the whole team so that it's not cumbersome, if you will. Those are some of the challenges that we've tried different things to overcome. So that's different, and it is different to be able to network with our colleagues, having the dental school, the nursing school, as well as the dental and nursing faculty and the DO and MDs there as well. I think we're going to touch on all of the topics and the pillars, if you will, that are so foundational in IDM, you know, airway, TMD, inflammation and infection, and make that where it's applicable in your office. We've brought so many fabulous speakers. If you haven't been to the IDM page and looked at the symposium lineup, it's incredible. And we couldn't fit everybody in that we wanted to have, actually. So we may have to, I don't know, add another day next year or something.
Yeah, we've actually been getting calls now from national speakers asking to participate, which is a great problem. Alan Reisinger is on the call tonight, and Alan is going to be participating in the symposium. And Alan, if you'll unmute, hey, Alan, if you'll unmute and tell us a little bit, you're an MD, and we're going to be talking with you more very soon, but Alan is the educational director for MD VIP, which is a network of MDs all over the United States, more than 1,500. And this is a strategic alliance that we are putting together with dentistry and medicine. And I'll tell you, one of our objectives is to create a network around the country that you all would be part of. And by that, I mean that we would have these key physicians, particularly through MDVIP, that would be trained in understanding the importance of oral health and understanding the oral microbiome, understanding the keystone pathogens and high-risk pathogens and why they must be tested and addressed and dealt with as part of overall health. But also, Alan and Laura and others are training the physicians around the country to understand, you know, how to treat systemic inflammation in a unique way. And so, Alan, tell us a little bit about what you all have been doing on the medical side and why you have, you know, been excited to connect with us.
Oh my gosh, absolutely. And I'm so honored to be part of this, Whit. I guess it goes back to when I joined MDVIP back in 2008. I got introduced to inflammation testing, which, you know, I don't think I had certainly never done anything other than an CRP, a C-reactive protein, in my career. I didn't know what a myeloperoxidase was. I had not used LPPLA2, hadn't used urinary microalbumin other than my diabetic patients. And it was part of the MDVIP model that we were going to test for inflammation. At some point, I got to my first Baldinine preceptorship and learned about all of the connections between oxidative stress and every chronic disease known to man, and it changed my career. From that moment on, I never had another heart attack or a stroke in my practice. And when I started referring my patients who were inflamed to their local dentist to search for an oral source, I all of a sudden got these dentists and hygienists calling me saying, "Oh my God, where have you been? We've been looking for a medical doctor who understood this stuff, who spoke our language, who even cared about the mouth." And I got lots of patients referred to me from my local dental colleagues. Long story short, I retired from my clinical practice. I became associate medical director at MDVIP, and the main thrust of my job there is to go around the country with Laura Hooper and Todd Eldridge of Cardio Risk with CIMT scanning, and we are bringing MDVIP medical doctors, their local dentists and hygienists in the same room together to learn about aggressive cardiovascular prevention and the oral systemic connection. And oh my heavens, there is nothing more fun for geeks like me than to look at the back of the room and see the light bulbs going off and see a dentist, a hygienist, and a medical doc sitting there with their heads together, talking about a patient that they have in common or that they'd like to have in common. So it's been very successful so far. We've done 16 7-hour lectures in 16 cities around the country. We're going to keep on going as long as we can, and we hope to be key in bringing the medical and dental communities back together again, separated back in the late 1700s.
That's right. Well, one of our dreams is that we will create a network that will be MDVIP physicians who have learned these skills and are committed to it, and then do the same with dentists and dental hygienists all over the country. So when we get these phone calls that are saying, well, I have a patient in Texas that has this issue, and I don't know who to go see, we have like 1 or 2 resources, and that's it. And we should have resources in every city and every state. And I think working together with MDVIP and what we're trying to do, I really believe that we'll be able to get that network where you can go, onto the website and say, who in California, who in Ohio, who in Dallas, who in New Orleans can I go see that understands this or refer to. And so we want to all be part of that together, but it's going to take some work. But having you on board is enormous and just so encouraging to us. And we thank you for your vision and leadership, because that's just huge. So thank you too for joining us in Knoxville and bringing the message of the physician's perspective on this whole subject that we're looking into. So I think, Gina, we may want to call it a night. It's 9/11 in Florida, so it's bedtime somewhere almost.
It is
like here, like here. I really want to thank Nathan and Dave for being with us and taking your time out tonight, Dave, for being with us and sharing just enormous information, but also for your commitment and devotion to what you're doing, the projects that are changing lives. And it's just so exciting. And I just like to always say we're kind of on the edge of the cliff, but there's no bridge in front of us. I mean, we're just right there, all of us together, looking toward the future. We're having to build the bridge. And it's people like you and Alan and Nathan, that are making that happen. And we want to do this together and someday look back and just be able to just smile with gratitude that we've been able to be part of something important. Meanwhile, everyone, we're meeting next month, aren't we, Gina? So
Yes,
what we decided to do, because we want to introduce you to as many people as we can who are going to be speaking and participating in the symposium, we've decided to do our study group 3 months in a row. So we're going to meet a month from tonight, the first Wednesday of March, and then the first Wednesday of April, and then we'll have our actual symposium in May. So we're going to bring 3 more participants in the symposium in March, and then 3 more in April to introduce you to their work and to be able to hear a little bit from them and get acquainted for them before we all meet together in Knoxville. So I hope you all are inviting people, including other hygienists and dentists and physicians and nurses, to consider coming to this symposium, because it's truly going to be, a collaborative interdisciplinary meeting, not just dental. And so we're so excited. We can't wait. And I hope that you feel the same way and that you're beside us and moving this ball forward. So Gina, I'm going to see you tomorrow.
Yes.
We're going to get some more training, which we need. And
Yes.
then we'll see everyone else in a month. And then
March
Dave
6th. On your calendar, everyone, March 6th.
March
Next
6th. And then Dave, we'll see you in May.
Thank you for the invitation to be here this evening. I really do appreciate it. It's
thank you so much. And so we'll we'll say goodbye for now, and we'll see you soon. Thanks, everybody.
Thank you, everyone.
Have a great rest of the week.
Good
Bye.
night.
Good night.